CAL's guidelines show that getting into a patient's chest sooner at bedside helps improve patient outcomes. This resternotomy cart helps simplify that process. Today, we will discuss the components of the cart and go over a mock resternotomy. On top of the cart, you will find a resource binder. Inside this resource binder, you will find resternotomy education. There is also the roles of a resternotomy placed on cards that will be handed out to each team member once a decision is made to enter the chest. You will also find necessary documentation that will need to be done once the resternotomy is done. Over here are the internal defibrillator paddles, and here are the Zoll defibrillator pads. When you open the drawers, you're going to follow the steps 1, 2, and 3. Door number 1 over here includes everything that you need to get you and the provider sterile. When you open it, you will find bouffants, a headlamp, surgical masks, eye protection, sterile gowns, sterile gloves. Please keep in mind that everyone who is not sterile will still need to wear a bouffant and a mask. Over on the door, we have included the sterile glove sizes of all of our CV surgeons. Drawer number 2 includes everything that you need to set up a sterile field. When you open it, you will find the betadine that is labeled step 1, the laparotomy drape labeled step 2, a scalpel, step 3, and the resternotomy tray number 1 labeled step 4. Under the drape, you will find sterile towels. Drawer number 3 includes everything that you will empty onto the sterile field. In here you will find the resternotomy tray number 2, a sterile basin and bulb syringe, sterile lap sponges, sterile suction tubing, and a sterile yoker. Okay, so now that we have discussed everything that's inside of this cart, let's go over a scenario. So you have a 68-year-old gentleman who underwent a cabbage ×3 yesterday. Your 2 mediastinal chest tubes have been putting out 200 mils of sanguineous drainage every hour for the last 4 hours. But over the last 30 minutes, the drainage has stopped, and your vital signs look like this. Five minutes later, your patient goes into VFib. The code blue button was pressed by the primary nurse. Code team arrives with a crash cart. Pads are placed anterior lateral fashion with one pad to the right upper chest and the other to the left lateral side. The patient was in VFib requiring 3 sequential shocks. These shocks should be administered within 1 minute of a patient going into lethal arrhythmia. The patient remained in VFib, so light compressions at a rate of 100 to 120 a minute were started with a goal systolic of 60 on the arterial waveform. The surgeon was called at this time, and it was decided to prepare for a bedside resternotomy. The resternotomy cart was brought in. 300 milligrams of IV push amiodarone was given to the patient. Rolls were handed out by the charge nurse along with bouffant caps for each person in the room. Compressions were continued by the compression nurse while the primary nurse began to get sterile. Medication administration nurse turned off all drips at this time and ensured suction canisters were set up. The surgeon then arrived and began to get sterile with the assistance of the charge nurse. One of the roles that the charge nurse assigns is that of the recorder. The recorder will be responsible for ensuring complete documentation on the code blue record and the resternotomy audit tool. The charge nurse then began to prepare the sterile field. External leads and pads were removed. The crash cart nurse ensured the pads were removed from the field and disconnected from the defibrillator. Betadine was then poured onto the chest by the charge nurse while the compression nurse continued compressions. Compressions are briefly held for the sterile laparotomy drape to be applied by the sterile primary nurse. If there is a delay in the surgeon's arrival, the compression nurse can don sterile gloves and alternate compressions with the primary nurse. The surgeon was then handed a scalpel by the charge nurse and the incision on the chest was made. At the same time, the charge nurse hands off resternotomy tray number 1 to the primary nurse to place on the sterile field. The surgeon then used the wire cutters to cut the sternal wires. Meanwhile, the primary nurse assembled the sternal retractor. As this is taking place, contents of drawer 3 continued to be placed on the sterile field by the charge nurse. The retractor was then given to the surgeon to open the chest. Warmed sterile saline that had been obtained by the runner was then poured into the sterile basin on the field. Suction tubing was handed off from the primary nurse to the medication administration nurse to connect to wall suction. The yonker was connected, so the surgeon could then suction the chest and evacuate any clots as needed. The crash cart nurse then handed off the internal paddles to the primary nurse in a sterile fashion. Resternotomy tray number 2 was then handed off to the primary nurse from the charge nurse. The connecting end of the internal paddles was handed to the crash cart nurse from the sterile field and connected to the defibrillator. Note, the defibrillator will automatically recognize the internal paddles and default to 10 joules. The surgeons will typically defibrillate at 30 joules. The paddles are then handed to the surgeon by the primary nurse, and the crash cart nurse charges the defibrillator in preparation to shock. The patient remains in VFib, so the surgeon chose to shock using the internal paddles. It took 2 shocks to convert the patient to an organized rhythm. ROSC was then obtained. The chest was draped with warm, sterile saline-soaked towels in preparation for the patient's return to OR. So you may be wondering what's inside the other drawers. While they are labeled on the outside, we will briefly go over what's inside each drawer. The first drawer contains sutures, pledgets, pop-offs, a suture removal kit, skin stapler, staple removal kit, surgical steel wires, sterile surgical blade, and sterile surgical scalpel. The next drawer contains an additional sterile wire cutter, extra disposable scalpel, extra bulb section, gauze, CHG wand, and iodine solution. The next drawer has a pacemaker generator, pacing wires, pacer cables, guide wire introducer needle, introducer catheter kit, and batteries. The bottom drawer contains a cordis, a Swan-Ganz catheter, chest tube insertion kit, chest tube atrium, extra suction canisters and tubing, and a pericardiocentesis kit.